If you look at the guidelines, there are very, very few medical therapies that have been listed in the guidelines. In the European guidelines, there's no class of recommendation even for medical therapy, and so the one option that does have class of recommendations is surgical intervention. And the issue with that is that recent studies, both from Europe and the United States, show that the in-hospital mortality for isolated surgical therapy for tricuspid regurgitation is up to 10%. So this is really a daunting risk for clinicians to accept, and therefore we're constantly now searching for less risky, so lower morbidity, mortality procedures, and those will be the transcatheter devices. So much lower risk, and at this particular time there are a number of different classes of devices. We've got the leaflet repair or leaflet coaptation devices, such as the Pascal device and the TriClip. We have annular devices, so the surgical predicate there is the annular repair, and so a number of different annular devices. And then we have orthotopic valve replacements, so just putting a new valve in where the tricuspid valve was. And then we have a whole nother class that really has no surgical predicate, which is the heterotopic valve replacement devices, and those go into the vena cava. So with those four different classes of devices, we really have a huge armamentarium that we're currently testing for both safety and efficacy and then outcomes. The results of the one-year outcomes for the CLASP TR early feasibility trial showed that there was incredible safety. There were very, very low rates of stroke and mortality, and there was a bleeding risk that seems to be related to how sick the patients were. But overall, what we learned that at 1 year, the all-cause mortality is low at under 11%, and that the heart failure rehospitalization rate is also very low at around 18%. And we don't have any randomized trials now comparing the therapy to medical therapy, but the one study that looked at propensity matched patients showed a 1-year mortality of over 23%. So what we believe we've shown with the CLASP TR early feasibility study is that we will be able to reduce the mortality as well as heart failure rehospitalization significantly. There was an analysis that we did looking at the site-reported heart failure hospitalizations the year prior to enrollment into the trial, and then obviously the 1-year heart failure rehospitalizations that were adjudicated by the CEC, and found that there was over 55% reduction in heart failure hospitalizations. So again, we think that the patients are not only going to feel better and be able to do more, but they're not going to be in the hospital and they're not going to be dying. There are some randomized trials that are now ongoing that will be extremely important to the field. At this particular time, given what we know about surgical risk, all the randomized trials are currently randomizing against medical therapy. So the Triluminate trial enrolled extraordinarily rapidly. It's still ongoing, but is, again, we may be able to see results relatively soon. The CLASP TR, which is the randomized trial of the Pascal device, is now enrolling. And then the TriScend randomized control trial is also enrolling, and that's the replacement device. So it's an orthotopic replacement for the tricuspid valve, and all of those, again, randomized against medical therapy, enrolling well, and we should be able to really understand better whether or not the devices are going to improve outcomes, and not only hard outcomes like mortality and heart failure hospitalization, but patient-centric outcomes, how the patients feel. We found out early on with some of the very, very first devices that we put in that just a 1-grade reduction in tricuspid regurgitation resulted in a tremendous benefit in how the patients felt.